Welcome to the Daily Brief on Metro Milwaukee's health and its economy, brought to you by the Medical College of Wisconsin and the Metropolitan Milwaukee Association of Commerce. I'm Tim Sheehy, president of the MMAC, and I'm joined here by my co-host, Dr. John Raymond, president of the Medical College. Every day at 3:30, we deliver a fact-filled 19-minute update on the health and economic impact of COVID-19. The webcast is powered by Aurora WDC. So I'm going to turn it over to Dr. Raymond to give us our daily update, at least during the week, of where we are with Milwaukee and Wisconsin's impact from COVID-19. Dr. Raymond?
Well, thank you, Tim, and good afternoon, everybody. I am pleased to provide the daily update on the MMAC COVID-19 scorecard. If I could have the first slide, please. Before we get to the scorecard, I'd like to briefly summarize some new CDC guidance from last Friday about cloth face coverings. As summarized on this slide, the CDC recommends cloth face coverings over the mouth and nose when any individual leaves their homes and could come into contact with other individuals. Examples of those situations could include trips to the grocery store or pharmacy, elevators, or common spaces in an apartment or condominium complex. Scarves, cloth masks, and bandanas all would qualify as an appropriate cloth face covering. Now, the rationale for cloth face coverings is to provide protection to other individuals by catching your respiratory droplets when you talk, sneeze, or cough. The cloth also might provide some protection to you if you're wearing the covering, but that's not the primary rationale. Other reasons to wear a cloth face covering include signaling that you're serious about social distancing, and it also could serve as a sign of solidarity. In other words, we're all in this together. The cloth face coverings do not substitute for social distancing and hand washing. It's important to note that this is an additional recommendation. We also recommend that individuals should not touch face, mouth, nose, or eyes, and absolutely should not touch the cloth face covering. An additional recommendation is that one should wash or sanitize the hands before placing the cloth face covering on one's face and after removing it. And finally, the CDC was very intentional about using the phrase cloth face coverings rather than mask. The CDC recommends that surgical masks, N95 masks, and face shields should be safe for healthcare workers and first responders. And right now, with the status of the PPE and the supply chain, I think that's a good recommendation. Okay, if we could go to the next slide, please. Last week, we showed you data that suggested that we were beginning to flatten the curve here in Wisconsin and in Milwaukee. Recall that our daily growth rate of new COVID-19 cases dropped from about 30% 10 days ago to below 20% last week. And the doubling rate of COVID-19 cases stretched out from 3 to about 4 days. Today, then, the positive trend continues. We had 108 new positive tests in Milwaukee and 173 in Wisconsin. The daily growth rates were down to 13.5% in Milwaukee and 13.4% in Wisconsin, showing continuing improvement. The doubling rates also continued to slowly improve and now have stretched out to 5.15 days in Milwaukee and 5.16 days in Wisconsin. Now, as always, we caveat Monday calculations because of reporting lags over the weekend, but the trends do look favorable. Thanks to everybody here and throughout the community for the sacrifices they're making to flatten this curve. You are making a difference. Now, having said that, despite the slowing rate of doubling and flattening the numbers of the new positive tests, local projections still suggest that our Milwaukee region health systems will reach their capacity of ventilators and ICU beds within the next week to 10 days. We must continue to push hard as we can. What we do now will impact what happens 1 or 2 weeks down the road and will help us get closer to the recovery phase for the health of our community and for our economy. Next slide, please. In that regard, as we begin to focus on what happens after the peak of this first wave of COVID-19, we're going to need to develop new metrics that can help us to make sound decisions about restarting the various sectors of our economy. Those metrics could help us to develop sound recovery policies and planning. Now this slide shows some preliminary thinking about what those metrics might look like. And I'm drawing some inspiration here from a recent American Enterprise Institute report from Scott Gottlieb and colleagues. Possible metrics for phased restarting could include a 14-day decline in the incident numbers of new positive tests, hospitalizations, and COVID-19 deaths here in Wisconsin. But I want to remind everyone that those metrics would only be meaningful if the capacity of our health systems was not exceeded at that time. Now, as we begin to discuss and refine these metrics over the next week, I also would advise that we learn from communities that are a few weeks ahead of us, such as Italy, Spain, New York City, and New Orleans. We also need to be prepared to adjust our recovery plans based on some external variables of which we may not have much control, such as trends in contiguous states, travel restrictions, and importantly, the availability of validated tests for COVID-19 and our ability to certify individuals as safe to return to work. Although I want to make it clear that social distancing is working here, and I want to thank and congratulate everybody for their great work, we must continue to stringently adhere to these social distancing techniques. The next days and weeks to come are crucial. But I also look forward to anticipating a pivot to discussing the phased recovery as we traverse through this current surge and the peak and tail of this wave of COVID-19. Thank you. Tim, I'll return it to you.
Good. So I don't want to get overly optimistic here on a Monday, Dr. Raymond, but it sounds like really good news in terms of the trend you identified in both the doubling time and the daily growth rate. So, you know, if those keep up over the week, would you say we have a trend going at least?
We definitely have a trend going. The question is whether the trend is enough to avoid exceeding the capacity of our ability to give people intensive care and to ventilate them if needed. And that's the big question. Right now, we're still tracking at going over capacity within 7 to 10 days. And so we need to flatten that curve more. Last Friday, you asked me where I would like the numbers to be on this Friday. I'd love for us to have a doubling rate of 7 days or more, and ultimately to push that out to about 2 weeks.
And then when we talk about the peak and the peak coming within the next week or so, is that the definition of the peak being underneath or over the number of potential hospital beds we have?
It's a great question, Tim, and no, they're two separate measures. The peak would be the highest number of patients that we have in the system or the highest number of new cases per day. We're hoping that that peak comes when we still have capacity left in the hospitals. That's why it's important to bend the curve down. But right now the projections are we're going to reach capacity before we reach the peak.
Yeah, and can you comment a little bit from a distance about what you see lessons in New York and maybe New Orleans and some other places where they have just been hit really hard by a peak that's almost overwhelming for them to deal with?
Yeah, well, I'd start with the perspective of the health systems. Our health systems here are really working together in an unprecedented way. And not just with each other, but I think with federally qualified health centers and the business and government communities here. And we are benefiting from being able to see what's happened elsewhere and to anticipate for that. I know that our health systems have created about 40% increased surge capacity within their own walls, which is very remarkable and responsible thing to do. So I would say there, the other lessons that we can learn is let's not get too optimistic too soon. We need to really push hard now and not restart things until we're ready to do testing and certifying people to go back to work. And those are variables that the health community really, we can't control those, but the business community can really help us to streamline the supply chain and to ramp up production of those tests once they're validated.
Yeah, and I certainly, Doctor, don't want to get you in trouble with any political pronouncements, but the discussion today about the governor's order to postpone the April 7th election, do you feel that, not asking about postponing the election, but do you feel that people could have or could vote safely? Or do you think that's just a real challenge?
I think it'd be difficult for people to vote safely. And I know that there were extraordinary efforts made here to try to identify sites where good social distancing could be practiced, but it would really be hard to keep the pens clean between voters, and it would take an extraordinary effort. I'm not saying it couldn't happen, but from a public health perspective, that would have been a difficult task to have the elections tomorrow.
And then one last question, and then we'll go to Chris for questions from the audience. We had a discussion last week about the auxiliary hospitals or facilities that could be set up. And you and some of the other healthcare professionals made a really good point that that works only if it's additive. So you can talk about some of the concerns if people start poaching talent or taking or using materials that could be used in the hospitals.
Yeah, very complicated. I mean, basically, the surge hospital would be built by the Army Corps of Engineers at their cost, but we would need to staff and supply and operate the surge hospital, which is going to create problems for us because we believe that by expanding the surge capacity within the walls of our existing health systems, that our talent base is already going to be tapped out, and that we won't be able necessarily to easily staff or recruit new people into the region to staff that hospital. You talked about poaching. New York and Chicago are offering extraordinary hourly compensation rates for nurses, respiratory therapists, and locum tenens physicians to go work there. And so we're actually feeling a pinch of recruitment away from the region here when we're really entering the phase that we need all hands on deck.
So really, as we've discussed, it would make it would work a lot better if we had some kind of a national strategy to deal with these rolling surges, and we weren't just picking each other's pockets.
I think that's fair to say, and I've been saying now for about a week that for us to get on the other side of COVID-19 and to recover our economy quickly, we need a coordinated national strategy, not just about talent and where we put these surge hospitals up, but the timing of when we exercise social distancing interventions. The problem right now is in some communities, it's been too little too late. I hope that's not what happened here. I think we had really good leadership that intervened early. But also staggering and patchwork implementation of these safer at home type initiatives from state to state. And even the states that surround us have not implemented the safer at home or the shelter in place guidelines at the same time. And that is a concern for secondary waves.
Chris, questions?
Yeah, for Dr. Raymond, we had a question. Is there a recommended number of layers for a cloth face covering that someone could use or make for themselves?
My wife and I had a conversation about that this weekend when she made my cloth face covering, which is actually quite nice. I would say tight weave cotton that can conform to your face, but not be uncomfortable is what you need. Remember, you're just trying to slow down the spread of these respiratory droplets. And I think any good cotton would be good. My wife actually made it so that I could slip a surgical mask inside, although I know that I'm not supposed to use a surgical mask, so right now I'm not doing it.
Absolutely. Along those lines, we had a question about something that some of the students at MCW are doing. I believe you said they're making masks for the community, or excuse me, face coverings for the community.
Thank you. Yeah, we are making cloth face coverings that we can distribute to the community and possibly to some of our own employees here as we begin to exercise the cloth covering guidelines here. One of the problems is many of the areas of the city that have the highest incidence of COVID-19 may not have access to these types of cloth coverings. So our students, I think, are able to make about 80,000 of these, and we're working to distribute them along with many other organizations like the 16th Street Clinic to some of the under-resourced communities through faith-based organizations and community organizations. And by the way, when they made the masks, we exercised very stringent social distancing.
Very good. We had a question about the use of hydroxychloroquine. Do you have an opinion on that? And are you aware of any trials or patient use that's being undertaken in our area here?
Yeah, it's a little confusing. Let me just start by saying I agree with Dr. Fauci that from the scientific perspective, there have not been adequate numbers of controlled clinical trials where you knew all the variables. Having said that, there are a few studies that suggest that it may be helpful, and it is okay for physicians to prescribe that as an off-label use according to the FDA. And so President Trump saying, why not? I can understand the attractiveness of that. But again, as a scientist, before we invest in giving a drug that can have side effects, I'd like to see some better studies. And I know that some are ongoing right now, and hopefully in the next week or two, we'll have better data.
And along those lines, that's not the only potential solution out there. There are other drugs that are under use right now.
There are, but I can tell you that we have more than 50 drugs that are under investigation. If there was a wonderful game-changing drug, we probably would know about it by now. It doesn't mean that we won't have some useful adjuncts as we go forward. We're going to need to define whether those are useful for prevention or early stage disease, or whether they're types of drugs you give to somebody who's in dire need and maybe an extremist. And those are the kind of things that we need to work out over the next month or so.
Another question from the audience. If someone has N95 or surgical masks, where can they go to donate them?
Most of our health systems have a hotline that you can call for donations. And if somebody wants to shoot me an email, I can connect you to Freightert. But all the health systems are collecting those.
Another question, if there's no known cure right now, what do the ventilators do and how do people get better?
Some people get better, many don't. What people die from, for the most part, from COVID-19 is severe acute respiratory distress syndrome, in which the capillaries of the lung become leaky and you have pulmonary edema. It's hard to oxygenate, and it sets off a cycle of inflammation. And those inflammatory mediators cause your blood pressure to drop and your organs to fail through shock. And so the ventilators really are just there to provide oxygenation and supportive care, while hopefully the body can fight off the infection.
Another question, are there any graduating MCW students who are being called into service today?
Not yet. And there is certainly a national debate about whether we should have students who are not licensed physicians yet be on the front line of the healthcare workforce, especially in areas where the licensed workforce is distressed, like New York and New Orleans. So there's no real answer. The AAMC, which is the accrediting body for all US medical schools, recommended a 2-week stand down of students so that they would be removed from the clinical setting. 1, to protect them, and 2, to preserve the precious amounts of PPE that were there. We didn't want the students consuming those. So it's an open question. It's a really good one, and I don't think there's a great answer yet.
Great, thank you, Dr. Raymond, and thanks to everybody who asked questions.
Good, yes, thank you again, Dr. Raymond. And I think as we reflect back on the weekend, the rising unemployment in the US, which is going to continue to rise this week, as this disease rolls through the impoverished countries in the world, and the really lack of quality healthcare systems and the impact that's going to have on folks, and the mounting debt on countries like Italy and others, and what that means for their future, along with depressed oil prices. And it's almost a cascade of really difficult information to process. So I'm happy to hear and understand, I'm not celebrating early here, that we're starting at least to talk about the recovery phase, moving from the spread phase, and what metrics we can begin to put in place as we talk about that this week to kind of get Wisconsin on the COVID comeback. And so I'll take that as a highlight this week, Dr. Raymond. Again, thank you all. And if you're interested, we also have a webcast tomorrow at 11. We're going to feature Dr. Raymond again with an update. We'll also have an exec from BMO Harris talking about banking issues and the PPP program. And then the CEO, Dan Cahalan of American Roller, to talk about and give advice on how he's addressing this challenge with his company and his employees. So thank you again for joining us. Have a good afternoon.